Welcome to the deep dive. We're here to basically cut through the noise and get you right to the core of complex topics.
Yep, straight to the point.
And today we're focusing on something really crucial for your revision, thyroid storm. You might also hear it called thyrotoxic crisis.
That's right. We've taken some pretty detailed revision notes and distilled them down. The aim is to give you a clear, memorable way to understand this.
Because it's a serious condition, right? Can feel a bit overwhelming when you first look at it.
Exactly. So think of this as your kind of streamlined guide. Our mission today is to equip you with a solid grasp of thyroid storm, the definition, causes, risks, all that key stuff to help you, really nail your revision.
Okay, fantastic. Let's get right into it then. What exactly is thyroid storm?
Okay, so in simple terms, thyroid storm is a life-threatening emergency. It's a very severe, very sudden worsening of hyperthyroidism.
Hyperthyroidism being the overactive thyroid gland producing too much hormone.
Precisely.
Mm.
And you'll hear the term thyrotoxicosis. That's basically the clinical state you get from having all that excess thyroid hormone washing around your system. Thyroid storm is like the extreme end of that spectrum.
So hyperthyroidism hitting a critical, dangerous peak.
That's a great way to put it. It's an acute, extreme manifestation. Now, it's relatively rare, thankfully, not something you see constantly. But, and this is the key thing, it's incredibly dangerous. It needs immediate aggressive action.
Right. And could someone actually present with this, like, out of the blue, without even knowing they had a thyroid problem?
Yes, absolutely. While it often happens in people who already know they have hyperthyroidism, sometimes this storm is the first sign.
Wow.
Which is why spotting the signs quickly and getting treatment started, right away is just vital. And it's often linked with Graves' disease patients.
Graves being that autoimmune condition where the body attacks the thyroid.
Exactly. Stimulates it to overproduce hormones. That's a very common background for this.
Okay, got it. So a dangerous surge of thyroid hormones. What actually triggers it? What causes this storm to happen?
Well, like you said, it nearly always happens in someone who already has hyperthyroidism, most often Graves's. But there's usually some kind of trigger event, a precipitating factor that pushes things over the edge.
Okay, like what sort of events are we talking about?
It's quite a range, actually. Infections are a big one. Any significant infection,
Right.
trauma to a major accident or injury. Surgery is another key trigger, and that could be thyroid surgery itself or even major non-thyroid surgery.
Interesting. So the stress of surgery.
Exactly, the physiological stress. Also, and this is important, suddenly stopping your antithyroid drugs if you're on them.
Ah, okay. Bad idea.
Very bad idea. And just, general major stressors on the body, things like a heart attack, a myocardial infarction, or a stroke.
So really significant hits to the system.
Definitely. Even metabolic crises like diabetic ketoacidosis, DKA, or severe low blood sugar, hypoglycemia. Childbirth can be a trigger.
Wow.
Pulmonary embolism, a clot in the lung. Certain medications, too. Amiodarone is one to know, used for heart rhythms.
Right.
And also radiographic contrast media, the dyes used in scans. They both involve an acute iodine load.
And iodine fuels thyroid hormone production, doesn't it?
Precisely. Other triggers may be less common, but still possible. Taking too many thyroid hormone tablets, someone vigorously palpating or examining the thyroid gland in a hyperthyroid patient.
Really? Just examining
If
it.
it's done very vigorously, yes.
No.
And recent thyroid surgery itself, as we mentioned. So it's a whole host of significant stressors piling onto that pre-existing hyperthyroidism.
That's quite a list. Okay, so thinking about who's most likely to get this, what are the main risk factors?
Well, the number one risk factor is simply having that pre-existing hyperthyroidism, especially Graves' disease, as we keep mentioning.
Makes sense.
And then a really crucial one is poor adherence to the antithyroid medication. If someone isn't taking their meds properly, their thyroid isn't controlled, making them way more vulnerable if a trigger hits.
Yeah, that follows. What else?
The triggers we just talked about, recent surgery, trauma, infection, they also act as risk factors in someone who's already hyperthyroid. And just having other sort of underlying serious medical conditions can make someone more susceptible to, it's often that combination, uncontrolled thyroid plus a trigger.
Right, the perfect storm, unfortunately. So, okay, we know who's at risk, what sets it off, what's actually happening physiologically inside the body during a storm.
So at its core, it's this massive, overwhelming release of thyroid hormones. especially T3, the really active form. And it's not just increased release, but also increased synthesis and even increased breakdown contributing to the high levels. This hormone flood basically sends the body's metabolism into hyperdrive.
Like putting your foot flat down on the accelerator.
Exactly like that,
Yeah.
which leads to that really high fever hyperthermia. And if it's not stopped, you get widespread organ dysfunction, even failure. It's a total system overload.
Sounds incredibly dangerous. Now, if someone comes in with these severe symptoms, the high fever, racing heart, maybe agitated, what else could be going on? What are the key differentials?
That's a really critical question for diagnosis. You've got to rule out other things that can look similar. The most obvious one is just severe hyperthyroidism, but not quite a full-blown storm. It's less extreme, less acute.
Okay.
Then there's sepsis. A severe bloodstream infection can definitely cause fever, rapid heart rate, altered mental state. There's overlap.
Any other hormonal emergencies?
Yes, absolutely. Pheochromocytoma crisis, that's a surge of adrenaline-like hormones from an adrenal tumor. That can cause sky-high blood pressure and tachycardia.
Right.
And another one, particularly important if there's been recent anesthesia, is malignant hyperthermia. It's rare, but a dangerous reaction to certain anesthetic drugs, causing muscle rigidity and high fever.
So how do you tell them apart?
It really comes down to the whole clinical picture. The specific pattern of symptoms, the patient's history, do they have known graves, any recent triggers. Combining all that helps differentiate.
Okay, so how often does this actually happen, particularly here in the UK? Is it common?
Thankfully, no. It's pretty rare in the UK. The estimates are around 0.2 cases per 100,000 people overall.
Okay.
And if you look just at people with hyperthyroidism, maybe only 1 to 2% will ever experience a storm. So, important to know about, vital to treat, but not common.
Right. Rare, but potentially deadly. So what are those key clinical features, the real red flag that should make you think thyroid storm?
The presentation is often quite dramatic. Thinking system by system helps. Thermoregulation. A really high fever is classic, usually over 38.5 degrees C, and it can easily go over 40, even 41.
Yikes, that's incredibly high. What about the heart?
Cardiovascular signs are prominent. Very rapid heart rate, significant tachycardia, often well over 140 beats per minute. High blood pressure is common too, initially at least. And there's a real risk of atrial fibrillation, that irregular heart rhythm, and even heart failure developing.
And neurologically?
Big changes there. Patients can be anything from agitated and delirious, confused, even psychotic, right through to seizures or slipping into a coma in severe cases.
Wow. What about gut symptoms?
Yeah, GI symptoms are common too. Nausea, vomiting, diarrhea, bad abdominal pain. And all that could lead to significant dehydration, which adds to the problems. Other signs you might see are profuse sweating, tremors. Oh, and sometimes jaundice, yellowing of the skin or eyes, indicating the liver is struggling.
That cluster of symptoms sounds intense. You mentioned overlap with stimulant intoxication earlier.
Yes, that's a good point to remember. Things like cocaine intoxication can cause high fever, tachycardia, CNS disturbances. So considering the history is vital. But ultimately, the diagnosis of thyroid storm is largely clinical. It's recognizing this severe constellation of symptoms in someone with hyperthyroidism, known or suspected.
So clinical suspicion is high. What investigations do you then order?
Okay, so first off, you've got to urgently look for that underlying precipitating cause we talked about. If it's an infection, so blood cultures, urine tests, maybe a chest x-ray looking for pneumonia, that's crucial.
Right. Identify a trigger.
Exactly. And then, of course, the thyroid function tests, the TFTs, you'd expect to see high T3 and T4, high T3 uptake, and a suppressed TSH, that classic hyperthyroid picture, often very pronounced.
And test to see how the rest of the body is coping?
Yeah.
Or not coping?
Yes, absolutely vital. You need to check for signs of organ decompensation. So kidney function tests, are the kidneys okay? Creatine kinase, CK levels, which can rise if there's muscle damage. Electrolytes are key, especially with potential dehydration from the vomiting and diarrhea. Full blood count might show anemia, low platelets, or a high white cell count pointing to infection. Liver function tests, LFTs, are important too. You often see raised liver enzymes, maybe raised bilirubin, causing that jaundice we mentioned. Other things to check might include calcium levels, hypercalcemia can occur, and blood glucose, as hyperglycemia is possible. An ECG is essential to look at the heart rhythm, check for AFib or other issues. Chest x-ray, as mentioned, for lungs or heart failure signs, and arterial blood gases, ABGs, to check oxygen levels and acid-base balance.
That's a thorough workup. Now, you made a point earlier. Does how high the T3 and T4 are tell you how severe the storm is?
No, and that's a really, really critical point for revision in practice. The actual level of the thyroid hormones does not reliably correlate with whether someone is in storm or how severe it is.
Right.
You can have someone with moderately elevated levels who is critically ill in a thyroid storm, and someone else with sky-high levels who isn't technically in storm. The clinical presentation, how unwell the patient is, the specific signs like high fever, tachycardia,
Yeah.
altered mental state, that's what defines the storm.
Okay, that's vital. So it's a clinical diagnosis backed up by tests. Given how serious it is, how do you manage it? Sounds like an all-hands-on-deck situation.
It absolutely is. It's a true medical emergency. You need a multidisciplinary team, endocrinology, intensive care, often others involved. The main goals are threefold, really. Stop the thyroid making and releasing more hormone, manage the severe symptoms aggressively, and provide really strong supportive care.
Okay, what are the specific treatments you use?
You hit it from several angles, usually all at once. Symptomatic treatment, first like paracetamol for that high fever. Identifying and treating that underlying trigger is key, like starting antibiotics straight away if infection is suspected.
Right.
Then beta blockers, usually IV propranolol. This is crucial for controlling those adrenergic symptoms, the racing heart, the sweating, the tremors. It provides rapid relief. If propranolol is contraindicated, maybe due to severe asthma, then diltiazem, a calcium channel blocker, can be an alternative.
Okay, block the symptoms. What about blocking the hormone production?
Exactly. That's where the antithyroid drugs come in, usually methimazole or propyltiouracil, carbimazole, which is commonly used in the UK.
Yeah.
These stop the thyroid gland from making new hormone. Then you add Lugol's iodine solution. This actually works fairly quickly to block the release of hormone that's already stored in the gland. Important note, you give the antithyroid drug before the iodine, usually about an hour before.
Ah, okay, specific order there.
Yes. And then corticosteroids. IV dexamethasone is common, maybe 4 milligrams every 6 hours. Corticosteroids do a couple of things. They reduce the conversion of T4 to the more active T3 in the body, and they also provide adrenal support because the body is under immense stress. Hydrocortisone is another option sometimes used.
Wow, that's a lot happening at once.
It is. And alongside all that is intensive supportive care. Cooling measures fans, cooling blankets to get the temperature down, and aggressive IV fluids to correct the dehydration and support circulation.
So you don't wait for the TFT results to come back before starting this?
Absolutely not. If you have a strong clinical suspicion based on the signs and symptoms, you start emergency treatment immediately. You don't wait for lab confirmation. Time is critical.
Okay, so can we summarize those key initial steps, like the main pillars of treatment?
Yeah, you can think of it in 4 key components for initial therapy. 1, antithyroid treatment, carbimazole or PTU, followed by Lugol's. 2, beta blockers, IV propranolol usually. 3, corticosteroids, hydrocortisone or dexamethasone. And 4, simultaneously addressing the hormone distribution, aggressively treating the precipitating cause, and providing that intensive supportive therapy.
Got it. Multi-pronged attack. So what's the outlook? What's the prognosis for someone who develops thyroid storm?
Well, untreated, it's often fatal. People can die from the hyperthermia itself, from dangerous heart rhythms, multi-organ failure, or sepsis. It progresses rapidly.
And with treatment.
Even with prompt aggressive treatment, the mortality rate is still worryingly high, somewhere in the range of 10 to 30%.
Wow, even with treatment.
Yes. But compare that to untreated thyroid storm, where the mortality rate is estimated to be between 50 and even 90%. It just hammers home how vital early recognition and treatment really are.
Those are incredibly stark numbers. What sort of complications can occur even if someone survives the initial storm?
Even with treatment, patients can unfortunately still suffer serious complications. Things like persistent cardiac arrhythmias, maybe ongoing heart failure, liver injury can occur, kidney dysfunction too. Neurological problems like seizures or even stroke are possible. And like we said, despite best efforts, death is still a real risk if treatment isn't timely or fully effective.
This has been incredibly informative, but also quite sobering. Before we wrap up, any memory tips, ways to help consolidate all this for revision?
Yeah, definitely. Mnemonics can be useful. For those triggers, maybe try something like ITFS, SMDC, PMOV, recently triggered it. Infection, trauma, surgery, stressors, misstroke, DK hypo, childbirth, PE, meds, overdose, vigorous palpation, recent surgery. Bit of a mouthful, but might help.
Yeah, maybe. What else?
For risk factors, remember the history of hyperthyroidism, grazes, and poor adherence, HHPA, for high hazard potential, always.
Maybe. I like that one better.
For clinical features, cluster them. Cardio, fast heart, high BP, neuro, agitated, confused, GI, upset, dehydrated, thermo, high fever. Remember the extreme nature, investigations. TFTs confirm, others check for damage and triggers. Management. Think of those 4 pillars: block production, antithyroids; block action, beta blockers; block conversion, steroids; and support the body. And that prognosis difference, 10–30% mortality with treatment versus 50–90% without that urgency, should stick.
Those are great tips, thanks. So just to quickly recap the absolute key takeaways, Thyroid Storm is a life-threatening worsening of hyperthyroidism.
Yep, triggered by various factors.
Presence with severe multi-system symptoms, high fever, tachycardia, altered mental state are big ones.
And needs immediate, aggressive, multi-pronged management.
Because early recognition and treatment drastically improve the otherwise grim prognosis.
Exactly. Really encourage you to go back over these points, see how it all connects: the pathophysiology, the triggers, the presentation, the treatment rationale. Getting that solid understanding is key.
Absolutely. And if you're looking for more comprehensive MSRA revision resources, definitely check out passthemsra.com. Loads of great stuff there.
And don't forget freemsri.com as well, another excellent source for free MSRA prep materials.
Great recommendations. So the final thought to leave you with: endocrine emergencies like thyroid storm might be rare, but vigilance and the readiness to act fast are absolutely critical. Recognizing it promptly can literally save a life.
Well fed.
Thanks for joining us for this deep dive today.